what I have in my instrument kit and what I find helpful. So hopefully by imparting some of that knowledge, you'll be able to take that into your practice. I'll also touch on post-COVID protocols. We'll talk about the Chief Dental Officer's advice. We'll talk about the FGDP guidance. And I'm also here to answer lots of questions. So if there's any questions at all, please post them on the chat, either to everyone, or you can just post them to me, whichever you prefer, and I will read them out at the end. If there's lots, you can hear me but can't see me, sorry. So there should be like a little box in the corner where you should be able to see me. Can anyone else see me? You can see, okay, great. So, okay, fine. Sorry, Joanne, I think you need to play around with your settings there. Okay, so I've got lots of windows everywhere. I'm going to close that one. Gosh, so great to see so many here. We have 66 so far, so look forward to seeing the rest. And perfect. And I'm going to get started now. So, introduction to the heart of hand instrumentation. Why is this important? Because if we're limited to hand instrumentation, especially in this post-COVID era, hopefully we need to equip ourselves with the knowledge of how to effectively instrument with hand instrumentation, with curettes and scalers. And we also need to realize that these can be just as effective as ultrasonics if used in the right way. So a little bit about me. For those who've heard me talk before, know who I am, I'm really sorry to bore you with this. Just a little whistle-stop tour. I qualified from the University of Sheffield, and I loved it. It was great. All my family live in London, so moved back to London and studied my 3-year periodontic specialty training at the Eastman. Had a great time there, and now primarily work in private practice. I do teaching days at the Eastman to the CPD department, especially the aesthetic masterclass courses and the perio courses they run there. So I enjoy going there every couple of weeks or so. Great. A little poem I found on Facebook recently. I thought it was really interesting, just to touch on COVID and pandemics. This was written in a pandemic in 1869. I'm not going to read through it, but if you can scan through it, it's amazing how history repeats itself. But out of tragedy, hopefully will come a time of reflection, learning, and we can get back to practice as we are the last week or two, and improve our skills. And yeah, I mean, lots of people have been doing lots of new skills over the COVID pandemic. Personally, a little silver lining is obviously spending lots of time with my daughter, who's 1 in 2 weeks' time, but also doing lots of gardening, which has been fantastic. And this is a Facebook group, Oral Flora and Garden Pathology. I mean, it's pretty ironic for a periodontist, a gum gardener, to be a member of this group, but I welcome all of you to join this Facebook group for all your gardening tips. Okay, so back to why you're here. So this is periodontics in one slide. Okay, we start with the systemic phase. We go to hygienic phase, which is our non-surgical therapy. We reassess. At that reassessment, we work out, do they need a repeat of the hygienic phase, or do they need a surgical intervention? Once they're stable, we take them to the maintenance phase. And once they're stable in that maintenance phase, if they have missing teeth, then we can consider dental implants. And that is pretty much what I do as a periodontist and what we do in managing patients with periodontitis. So if we start with a systemic phase, it's about identifying risk factors. We're looking at whether the patient smokes, so diabetes, obesity, metabolic syndrome. That's a combination of syndromes of high blood pressure, of pre-diabetes, so borderline diabetes, obesity. So it's a combination of different syndromes that we call a metabolic syndrome that's been related to increased instance of periodontitis. Stress, pregnancy, diet, alcohol, lots of different ones, and more are arising as research continues. And all of these are important to appreciate if we are empowering our patients to understand the bidirectional relationship between many systemic conditions and their oral health. Yes, via video conferencing. Sorry, I thought, why did I write that? Via video conferencing, all this can be done in the post-COVID era via video conferencing. So like I'm talking to you on Zoom, you can talk to your patients on Zoom. You can take your history, find out in the systemic phase, identify the risk factors while talking to them on Zoom. When you've got your mask, I mean, there are some horrific looking masks which are out there. I'm personally got this ridiculous Darth Vader-esque mask. You can't talk to patients very well with these masks on. So having a chat with them, talking to them about the systemic effects of periodontitis on a screen like now is much more efficient than second guessing what you're trying to say through a mask, because it's very difficult. It has been a real challenge this week. So as much video conferencing you can do in practice, I think is great. And if you can try and set some side of time in your diary for it, I think it's really beneficial. Smoking, it's the 3 A's, all of this via video conferencing. Ask if the patient's a smoker, advise them the best way of stopping, and build confidence and give them a plan. Focus less on the damaging factors because they know it already. Focus more on how to get them a better pathway to stop more efficiently. And it's the same with diabetes as well. We need to talk to them and talk to their physicians as well. And this all can be done via video conferencing. So from this perspective, the only change post-COVID, I think more can be done without seeing the patient in the flesh. And identifying risk factors, this little cartoon here, for me, sums up public health in a really great way. Your river of disease, and we are dragging them out. We are the ambulances. As dentists and hygienists, we are providing non-surgical therapy, scooping out the bacteria, scooping out the disease, trying to get them better by pulling them out the stream. We need to focus on the manufacturers of illnesses and the illness factories in trying to stop them fall into that disease stream. So, onto the hygienic phase, which is what we're going to focus on today. We all know that gingivitis is reversible. And a big part of what we do as dentists and hygienists is motivate. Again, motivating with a mask is really difficult. So I think video conferencing has a role to play, especially in the early phases of this pandemic for the next month or two, to be able to try and motivate them, see what they use at home. And I think in this pre-treatment visit, we can go through that. You can go through a systemic phase, you can go through the hygienic phase in discussing their oral hygiene. They can bring their brushes to the screen and you can talk about different types of brushes. When you see them in the flesh, then you can talk through what fits, what TP brush fits where, or what interdental brushes fits where. But I think this is an important conversation to have before. Removing local factors. This is a big, important issue as we need to make it easy for the patient to be able to clean. And if you're a dentist, then this should be done before the periodontal or during the periodontal, non-surgical periodontal therapy. And as a hygienist, either to notify it to the dentist, refer back to the dentist for it, or if you're a therapist, and to adjust or replace the restoration as prescribed as well. So this is an important factor. So going back to oral hygiene advice, lots of different ways you can brush your teeth. Lots of different studies will show you different ways of different effectiveness. Overall, one way isn't better than the other. But it's whatever suits the patient best. Often it's easier with an electric toothbrush, but not for everyone. So it's important to go through this journey with the patient, and when you see them, to disclose them every time. I'm going over this really quickly because I kind of feel like these are all the bits which you should know before I talk about non-surgical therapy, but then I want to focus on non-surgical therapy. So I'm going through this just as a good baseline. Motivational interviewing. This is really important because just talking to them saying, you should use this incidental brushes here or use that single tough brush there is not motivating a patient. You need to understand what challenges a patient has in their own personal life. Do they have children they need to drop off school in the morning? Do they have night shifts they work on? When is best for them to brush their teeth or to spend time? And that's the whole part of the motivational interviewing, which could be a whole different lecture. If you'd like me to do one on oral hygiene instruction motivation, happy to do one. Yes. Okay, great. Oh, thank you. I won't do it now because otherwise you won't get what you're asking for, which is a non-surgical bit and the hand instrumentation. But no, definitely, it's a really important part. Non-surgical debridement. So we get to the bit where we're actually picking up our instruments and scaling. Do we do quadrant by quadrant, full mouth disinfection, ultrasonics versus hand instruments? Now, the last one is obviously the one which you're really keen to know about, and I'll get to that in a moment. So the full mouth disinfection protocol, okay, so that's providing within 24 hours the whole mouth of non-surgical debridement, scaling and replaning. You're using chlorhexidine, you're scrubbing the tongue, spraying the tonsils, and this was the original protocol from Quirinen, the Leuven University Leuven in Belgium. Compared to quadrant by quadrant, so this is a bit more information on the actual protocol. I did see a hand raised. If there's a question, it's much easier if it's okay if you could put it on the chat, and then I'll go through them all at the end, just because otherwise too many boxes and I get confused. So is there a difference between quadrant by quadrant or full mouth disinfection? No. So whilst it's a nice idea to be able to get rid of the niches in one go, we find that the actual outcomes in terms of pocket depth reduction and clinical attachment gain is there's no difference between the two protocols. So when would I do one over the other? Full mouth disinfection protocol, you'd have to have the plaque scores below 20% before you start, because if you're doing all of the non-surgical in a short space of time, you do not have that repeated visits for oral hygiene motivation. So they have to be already very motivated, and they have to be very time poor. And so if they can't see you every week for 4 weeks, then full mouth disinfection could be a treatment protocol you could use. Quadrant by quadrant, I tend to prefer for all patients, because each time you see them, you can go over certain areas. If you see recession and calculus, which you've left behind, you can get rid of it second time round. So it's more forgiving in that sense. And also you can see them on the journey. Every time you see them, when you disclose them, you can see they're getting better, give positive reinforcement. So personally, I prefer quadrant by quadrant, although there's no right answer. Both are as effective as each other. And then ultrasonics versus hand instruments, which I'll go on to next. I'll go on to that after, actually. Well, ultrasonics and hand instruments are the differences between them. Effectiveness wise, there shouldn't be any difference. I'll talk to you about what the differences are in terms of outcomes in a moment. So we've done the non-surgical therapy and we go to the reassessment phase. We wait around about 8 weeks. The reason why we wait 8 weeks for the reassessment is because we're waiting for the inflammation to reduce, the granulation tissue to subside, for collagen to restructure, and for the healing to occur. And that takes around about 6 to 8 weeks. Also, if there's plaque at the supragingival level, it reestablishes the pre-treatment microbiota in the pocket at 8 weeks. So we don't want to leave it too long. So 8 to 12 weeks tends to be the perfect time to reassess after our non-surgical therapy. And this is the type of healing we get. We get healing via long junctional epithelium, and we get recession. So those are the two things that happen during the non-surgical phase. And we know that long junctional epithelium is as resistant to future destruction than an intact connective tissue attachment pre-treatment. So in a healthy site. So we know that long junctional epithelium is sustainable long-term and protective against future breakdown. And it works. We get great results with non-surgical therapy. This is a little summary. This is an old systematic review, but an important one. It shows us with hand and ultrasonics, the type of reduction we get when we're treating our patients. So I'm going to focus on the bottom line here. I think you can see my cursor. If I could get a nod from Chris, can you see my cursor on the screen? Oh, good. Okay, great. Thank you. So if it's above 6 millimeter pre-treatment, we expect a pocket depth reduction of around 2.2 millimeters. Okay, so that includes a CAL gain, so clinical attachment level gain of 1.3 millimeters, and then another 0.9 millimeters of recession. So that's pretty good. And if you look to your own patients and think, okay, I've got an 8 millimeter pocket, or let's say I've got a 7 millimeter pocket, I'm going to get that to a 5. Is that realistic? I think it is, but it needs to be done on the same protocols that Cobb had in his inclusion criteria for his systematic review. So his systematic review, they had very strict oral hygiene, okay, so very low plaque scores. You had around 10 minutes, well, anytime between 6 and 12 minutes a tooth. So it's a lot of time spent debriding a tooth. And when using ultrasonics and hand instrumentation, if we're switching to hand instrumentation only, we need to account for that time. So it takes a long time. And we need to, when we think, okay, how long do I need to see this patient for? Count the amount of teeth which you need to treat. Count maybe 6 minutes for an anterior tooth and 12 minutes for a posterior tooth. Count 10 minutes to numb the patient up and consent. Count 10 minutes for notes and clearing away. Generally say it's a good hour per quadrant. Okay. So back to this question, which everyone wants to hear, I'm sure. Ultrasonics or hand instrumentation, which wins? Well, there is no winner. They're both great, but both do different things better than others. So this systematic review looked at different randomized controlled trials comparing differences between hand and ultrasonics. What they found is very little difference in terms of attachment level gain or pocket depth reduction. But what they did find a difference for, especially with Lorella Peterson's study, is time. Hand instrumentation, so HI's hand instrumentation versus mechanical instrumentation, there is difference in time. So our conclusions from the study, there appears to be no difference in efficacy of subgingival debridement of single-rooted teeth with ultrasonic or hand instrumentation. And there's no evidence available for posterior teeth, because most of these studies exclude molars. So there isn't the evidence for molar teeth, but we can, if we extrapolate for anterior teeth, there's no difference. And if we treat a multi-rooted teeth and if there's ossification involvement, we treat each root as an individual tooth, allowing the time, then we can extrapolate for that there shouldn't be too much of a difference. It may be faster with ultrasonics. Personally, I don't find it faster. And one way I check is when I've done hands-on course in the past, I get an egg and I get my ultrasonic and I make a little square, centimeter square on the egg. And then I do the same with hand instrumentations. And I know this is an egg and it's not real, it's not a real tooth. It is a real egg, but not a real tooth. I seem to be much faster with hand instruments. This may be different for people, for different people. So this is not an exact science. Personally, I think it's pretty much the same. What I like with the ultrasonic is you're constantly flushing and irrigating the pocket and you're not leaving any debris behind, which is nice. But with what you're missing with ultrasonics is a tactile sensation, and that is everything you get with your hand instrumentation. So the one thing, so at the moment, I'm suggesting really ultrasonics are the same as using hand instrumentation. So if we want to minimize aerosol, just use hand instrumentations. Where I think it gets a little bit tricky is vacations, because the width of a curette is around about 0.75 to 1.1 millimeters. And the entrance vacation are usually less than a millimeter. So depending on the entrance to vacation, like you can see down here, it might be really difficult to get hand instrumentation in. There are other instruments, hand instruments out there, which are thinner and can get into these areas. So you've got the Micro Mini 5 curette, even the Mini 5 can get in those areas. You can get diamond file scalers, neighbors shapes. You can get other things you can do to try and get in the vacation area. Or if you have the PPE, you can use ultrasonics. But I'll talk about that in a minute. So, limitations of non-surgical therapy. As you can see in this video, how good it works. I don't have one with a hand scaler. I never filmed one with a hand scaler, but on this extracted tooth with the ultrasonic, it takes a long time to get rid of this stubborn calculus, which goes back to the Cobb study. We need to spend a lot of time, and if it's 6 to 12 minutes, maybe we need to err on the side of 12 minutes for each tooth, especially with hand instrumentation, especially if you're not used to doing so much hand instrumentation. Overall limitations of all non-surgical therapy is operator experience and time, depth of pocket, the anatomy, so if there's vacation involvements or root grooves, patient risk factors, systemic factors, their healing potential and their compliance. All these things play a role. So there is still a role, even in this post-COVID era, for more advanced treatment and for surgical treatment, and the role of a periodontist. Now, I would say that, wouldn't I? But I am going to show you some of the Chief Dental Officer's guidance about that, about when is the right time to refer or to re-debride. So we get back to our diagram of what periodontitis is in the slide, or what treatment is in the slide. And this, we need to consider this directional relationship, or if they're ready, if they've got no probing depths above 4 millimeters, low probing, bleeding on probing, low plaque levels, and they are in the currently stable criteria of the BSP classification, if that's what you're using, then it can go straight to the maintenance phase. If not, then we need to consider whether we need to go back to the hygienic phase, especially if the oral hygiene isn't optimal. And if it is optimal, but they still have residual pockets, we need to consider, if there are no local factors, whether the surgical phase is indicated. So this guidance was produced in the document from the Chief Dental Officer. And I think this is quite practical, really. It's quite good. And what we're looking at here is pretty much the same as what we did pre-COVID. So there's no difference here. What they're recommending is hand instrumentation, because you're avoiding the aerosol. And with hand instrumentation, as I've shown you with the evidence we have, it's equally effective at removing subgingival deposits. It talks about retreatment of non-responding sites, and it also talks about repetition of set 2 plus or minus referral for surgical intervention. It talks about trying to reduce the patient travel to specialist centres, here we are, but don't compromise the patient's, whilst also not compromising patients' safety. But also, and at the same time, you don't want to be delaying treatment if it's severe. So if it's severe, then there's a reason for them to make that journey. And if they're low risk, take each patient on a risk-by-risk approach. If you have a very elderly patient who's got lots of comorbidities, then perhaps referring them at this time is not the right time, and it should be managed in primary setting. However, if they are low risk, they're not responding to periodontal non-surgical therapy, then a referral could be indicated. I'm going to follow that up with some more practical advice about what we should be wearing in our surgeries. This was from the BSP, and it talked about PPE level 2 and 3, 2 being a visor, a IRR fluid resistant mask, gloves, obviously, and all the things we used before, plus really a visor. And it also talks about using high volume suction with non-surgical therapy. If you're working with a nurse, this can be facilitated quite easily. If you're not, it can be quite tricky. What I would advise though is perhaps retraction with Optrogates are quite good. I'm sure there's others out there, but retraction device, and also you can get some of the aspirators have a side to retract at the same time with a mirror in the middle. I can't remember the name of it, but there are different devices out there to make it easier for you. I think good retraction is the easiest thing. Something like an Optrogate or one of those cheap retractors are good to put in there. And if you are using ultrasonics, it is a high risk. That doesn't mean you shouldn't use it, but if you do, you need to have the right level of PPE and you need to risk assess the patient beforehand. And this is from the FGDP. So it talks about aspirational, so what we'd all like to be wearing. It talks about the basic level, which is expected. And it talks about the conditional. So these are conditional based on the risk of the patient. So if the patient is a high risk, if they are over 70, if they have comorbidities, if they are COVID positive, then it talks about the level of appropriate PPE. Really, I think if they have the symptoms, then perhaps it's best not to see them for routine non-surgical therapy and only for emergency care, or refer to emergency urgent dental care centre with a facility for that. So conditional I don't think applies here, but basic and aspirational definitely does. And if we're at a low alert level or low risk AGE, then the basic we need is fluid resistant surgical mask and appropriate eye protection. And periodontal procedures with periodontal debridement with hand instrumentation with high volume aspiration is a low risk procedure. Using ultrasonics is a high risk, and therefore if it's a high risk, you'll need to be using your, well, ideally we need to use your FFP2 or FFP3 mask. So if we look on the left, I mean, I'm sure most of you have seen this, but if you look on the left, this is a kind of level of protection you would need for type 2, plus the eye protection you would definitely need. And for a aerosol generating, you'd need a filtering face piece respirator, so one of the more advanced masks. Okay. So can we use ultrasonics? Yes. However, do we need them? For now, at least, I feel like I'm working my practice without them. Things might take a little bit longer, but I think we should just go back to what we know, go to basics, and treat periodontitis effectively using hand instrumentation. That's my view, at least. Okay, great. So on to the differences between, this is more of the practical side, differences between scalers and curettes. And I'm sorry if I'm teaching some people to suck eggs if they are aware of these, but it's important to go and talk about the anatomy of your instrument before you start to use it and before you start to sharpen it. And that's the other. Oh, good. I'm pleased someone agrees with me about the ultrasonics and that. No, thank you. No, I agree. We have a good alternative, so why not use it? Okay, so if we talk, well, I'm going to focus more on curettes today because we're talking more about subgingival debridement and treatment of periodontitis, but the same can be extrapolated for scalers, which I'll talk about as well. Both curettes have a round bottom or back to the instrument. That is to not traumatize the pocket. So scalers have a V shape, and if you were to place them subgingially, you'd cause lots of bleeding. And curettes don't. And it's important when you sharpen them to be able to maintain that beautiful round atraumatic curve on the back of the instrument. Universal have two cutting edges, one here and one here, cuts both sides. Gracie's have one side cutting. And I'll talk about why they have that and why some people would say, oh, it's much better to have two because it's two instruments in one. But there are disadvantages to that as well. So there's advantages and disadvantages to both. And I'll talk about the differences and my preference. So universals. So this is a terminal shank, the last part before the blade. Okay, so terminal shank, when I'm talking about that later on, when I'm talking about sharpening and when I'm talking about direction of your instrument when you are debriding, that is a really important terminology which you need to get to grips with. So we've got cutting edge both sides, it's rounded on the surface, and the flat surface, the facial surface, is 90 degrees to the terminal shank. Okay. Now, to engage the cutting edge with a universal, you need to tilt it 70 degrees. Now, some of you are thinking from the Gracies, there's a 70-degree slant. That is exactly the reason why there's a 70-degree slant with a Gracie. You don't need to tilt the instrument when it's a Gracie, but you do with an ultrasonic. With a universal. So you do need to tilt it with a universal, you don't need to with a Gracie. So you need to put some lateral pressure and a pull-up stroke. Now with your ultrasonics, you're going from top to bottom. With hand instruments, you go from bottom to top. Okay, it's important to go from bottom to top and not stop halfway, because otherwise what you end up doing is burnishing the calculus and smoothing it on the root surface. And then it makes it harder to remove. With a Gracie, you've got an offset. So you've got one cutting edge and a non-functioning edge, okay? The offset creates one cutting edge, and that's the lower edge. And it's 70 degrees to the terminal shank. The terminal shank always stays parallel to the tooth surface with a Gracie, no tilting required, which is why they're so much easier, in my opinion, to use. You just put lateral pressure, no tilting, and pull up, maintaining the parallelism of the terminal shank. You can go sideways as well, but when you're doing side strokes, again, you need to keep the terminal shank completely parallel to the surface which you're scaling against. And with the Gracies, they are numbered. So this is a Gracie 1, 2. You have the one side this side and the two side this side. Now, this is a PDF from Hugh Freedy, and I think it's really good if you all had a copy of this. I'm going to try at the end, see if I can upload it onto your screens. I don't know if that's possible. I'll have a play around at the end. If not, if Chris, if you wouldn't mind putting your email on here, and for any of these documents, we can send them out to you. I think for those who've subscribed to my to my webinar, who've opted in, I'll send these out to you as well. Oh, sorry, I didn't even talk about it. Let me go back. So this is color-coded chart is really good. The instruments are color-coded, and it talks about which ones you use where. So you can use the 1, 2 Gracies or the 3, 4s anteriorly. Use the 5, 6, 7, 8s on the buccal or palatal surfaces. Sorry, the 7, 8 or 9, 10 on the buccals or palatal surfaces. Use the 11, 12s or 15, 16 on the mesial aspects, and 13, 14, 17, 18 on the distal. The only differences between, let's say, the 11, 12 and 15, 16 is 15, 16 is further angulated for the really big mouths. Personally, I don't use a 15, 16. I'm going to talk about what I use in my kit here. So this is a picture of my kit, which I love. and enjoy. Hollow handles, personally, I find much easier. You don't squeeze them so hard. They balance in your hand much easier, and you don't apply too much pressure. If you squeeze them too hard, if they're rubber, squishy handles, I tend to do the pulling motion, which you should not be doing with scaling. When you're scaling, you want to, if I'm getting an egg here, you want to be able to rotate your whole elbow. I don't know if you can see, I'll move back in the chair, maybe that's better. Okay, you want to keep your wrist completely flat and straight, no pulling up. If you have a squishy handle, that can cause you to pull up. That's not, I mean, lots of manufacturers do have squishy handles, including Q3D, but I personally don't like them. I like the metal handle for that reason. You're less likely to grip onto them as hard. What I have here is the first is a diagnostic stage. So I split my tray into a diagnostic stage. I've got my UNC 15 probe. You've got 15 markings. It's very easy to read your probing depth. They are 0.4 millimeter wide. So it goes into the pockets easily, and it's weighted as well perfectly. So you don't need to push, and that 0.25 newtons of pressure is by dropping the probe into the pocket. This is an Explorer. It's an 1112 Explorer. It's shaped like an 1112 scaler, but it's just a very thin probe, and you can use it to fill calculus. You don't need this. I like it just because you get that tactile sensation, but you can use with hand instruments, you can use all your hand instruments as Explorers. You just be very gentle and you feel the root surface. And as you're going down onto your egg, which you're doing at home in front of your Zoom, you can feel the textures on the egg, you can feel the textures on the tooth, and when you get a right big bump, you know you've hit gold or calculus. Okay, so these are the Explorer, that's the Explorer. Next one along is my neighbor's probe. Neighbor's probe is really important to check your furcation involvements. Before the black band is grade 1, into the black band grade 2, and when you're through and through, you can see your probe at the other side of the tooth, you're grade 3. Now, with your furcation probe, why it's important with non-surgical therapy is because when you have the patient completely numb, it's your perfect opportunity to really assess what the furcation involvement is like. Because usually when you check the furcation when they're not numb, the patient says, ow, and you don't get a good reading because you don't want to hurt them. So you tend to underestimate your furcation readings, where if they're numb and you're doing non-surgical therapy, it's always good to recheck them. So I have one in my debridement tray. Next one along, I have the Gracie 1-2. Okay, so that's one with a presetting of a 70 degree. I have a 1-2 mini. There's lots of variations of the same instrument. There's 1-2 rigid, there's 1-2 mini, there's micro mini, there's lots of different ones, which Chris will be able to talk to you about. I like the mini just because with a smaller blade, it's easier to go around, especially these lower incisors or it's hard to reach areas. You can also use it for the furcation areas where it's hard to get a bigger instrument through. Next along, now I'm skipping from a 1-2 all the way to a 7-8. Personally, I don't think you need every single instrument. You just need the ones for different things. So the 1-2 is for anteriors, 7-8 or 9-10 is for your buccal and your palatal surfaces. I also use it for premolars as well. It's just a little bit more angular, a bit more of an angulation. So if I hold, ooh, where am I? Am I going in the right place? No, there I am. If I hold them together, this one underneath is a little bit more angulated to be able to reach further back. I think I've actually got a slide on each one of these, so I'll go through them again. So Gracie 1-2 anterior zone, amplifications. 7-8 buccal, lingual, and palatal. And also I tend to use them for the premolar region, medial and distally as well, just because with that extra bend you've got here, you're able to reach in those areas. I have my Gracie 11-12, okay. They have, so if you can see in the bottom left of the picture, I'm showing the application of where to apply. And this is also in the Hugh Freely catalogue, which Chris can distribute to you. And if this is very crude, if this is a tooth, the mesial aspect is here. I'm scaling the mesial aspect of the tooth. So mesial only. So this is for the buccal aspect, and you use the other side, your 12 part for the lingual surface. Gracie 1314. See, it's all nicely coloured. There's a nice blue. It's the distal aspect. Okay, and you can see here, it's scaling root planing on the distal aspect of this lower first molar tooth. Now, then it gets all just personal. There's no right answer. I tend to have a couple of universals in my kit, simply because they're a little bit more aggressive and sturdy and thicker. So I have a Columbia, which is a type of universal curette. It cuts both sides. It's quite rigid, and for those really big chunks of calculus or inflamed tissue, it's really quite useful. So I have one there. It cuts the cutting surface is on both sides, so you can use it mesial and distal of a tooth. I don't use this for routine non-surgical debridement because I think it's too traumatic. But for certain instances, I have one ready in my tray. And then I have my last instrument. Now everyone has different. This is just me. It's a pointed McCall curette. It's not really a curette. It's pretty much a scaler, because I don't think you'll be able to see it on here, but you'll have to take my word for it. The bottom of the curette is like a V shape, which is like a scaler. This curette can be used supra or subgingival. Subgingival, if you use it, is quite traumatic, but it's tough and gets really stubborn deposits off. So that's why I have it, but it works really well, even anteriorly, for supragingival calculus. So I use this as my scaler for supragingival calculus, and occasionally for subgingival if it's just really, especially if you want to get into a root groove, it's pointed, it can really get into that root groove. Okay. That's my kit. I'm going to talk a little bit about sharpening. Actually, I think before sharpening, I'm going to talk about technique, and then I will talk about sharpening after. So if we go back to the Gracie 1-2. For Gracie 1-2, if you hold your egg with me, if you're doing a scale along, if you're not, I'll see if I can record it and put it on YouTube for a week or something, and then you can practice at home. If you take your egg, okay, or even your pencil, whichever. So a pencil works just as well. The lower edge is the cutting edge. This is your tooth, it's parallel. I'm scaling with the terminal shank, so that last bit here, oh, I'm pointing to the wrong bit in the camera. This bit there, parallel to the tooth. I'm holding the curette with my thumb, index finger, and then my middle finger over the top to control it. And I've got my fourth finger as a rest. Okay, so it's your modified pen grip. So I'll start that again. Thumb and index finger, middle finger over the top to control it and move it and twist it. And fourth finger is your rest. I'm placing it parallel to the tooth, to the pencil. And I'm not pulling up with my fingers. That's the worst thing you can do, because you'll get, after 1 week of debridement back in your practice, you'll get really sore wrists or carpal tunnel. So you move your whole elbow. It's quite hard to do while I'm looking at the screen seeing myself, but move your whole elbow up and down. Okay, so you look a bit like a chicken. Okay, that's the best way to do it. Eggs you can do as well. With eggs, you just do it So you scale to remove the brown surface so you can see a white surface underneath. Don't go all the way to the membrane. This is a good one to use because then if you put too much pressure, you know you're putting too much pressure. And look, within a few strokes, we've got a nice little square there. Okay, so this is a really good thing to practice on. Okay, perfect. So when you've got your angle curettes, like your 11-12 for your mesial aspect, you're keeping, it's exactly the same, you're keeping your terminal shank parallel to the tooth or the egg. I don't know if you can see that. No, my finger's in the way. Okay. And again, would you advise boiling the egg first? Love that question. This is not boiled, okay? This is a raw egg, and don't boil it because that's cheating. The whole point is if you make a mistake, you've got egg on your face and you've got to start again. So that's the whole point and the whole bit of fun. I mean, you can boil the egg. I'm just being silly, but you don't have to. Any advice for reducing fatigue? To be using hand instruments longer than usual. Good. Yes, it's all in the technique of keeping them sharp. If you over sharpen or sharpen with the wrong angulation, you wear them faster. It's also the type of instruments as well. Some instruments have coatings, say you don't need to sharpen them, but then as soon as the coating wears, they don't sharpen well. And then if they don't sharpen well, they wear very quickly, and they tend to become useless quite quickly. And so I don't like the ones with the coatings, which are non-sharpable. They need to, they have, it's important to sharpen them well, and I'll talk about that in a moment. Okay, happy to answer, because this is more of the informal part. I'm happy to answer any questions as we go along. If not, I'll go to sharpening, and then we can go back to scaling tips and tricks later. Okay, this document as well you can get from Chris is a really, really good way. It's a Bible of sharpening your instruments. I actually do it in a very slightly different way, but it's still the same principles. Use the clock surface and work out where you're going. You can print out different lines. If you put on a piece of paper and you mark where 5 minutes past 12 and 5 minutes to 12, you can even line it up on the piece of paper as well. So there's lots of different ways and guides you can use. But this is, as I find, the most simple way to sharpen your instruments. Different stones you can get. You can have an Arkansas stone. It's a natural stone. It's fine and works really well. You can get ceramic stones. Personally, I find you've got to apply. I feel you've got to get more pressure to get the same result. I don't feel it sharpens as effectively as an Arkansas stone, but people have their preferences. The good thing about ceramic is that you can use water to lubricate it. With an Arkansas stone, you need oil, but that's not such a bad thing. India stone is synthetic stone. It's really quite abrasive, and you'll need to use one of the other stones afterwards to finish it off. Your India stone is if you're going through your drawer of instruments, like the grave of instruments, and ones which haven't been used for years, and you think, oh my God, these are not usable, and you think you want to sharpen them to some kind of realms of usability, then perhaps an India stone will save you some time because it will just go through them faster. But really, you can just use any of the 3 stones, they work. Sharpening machine, I'm going to leave that, if that's okay, to Chris, simply because, sorry, I'll give you time, because I don't use them. I find it's, personally, I find it so simple to actually do it yourself. I just do it myself. I could be wrong, and there could be great benefits into using a machine. But I feel I can do it myself, and I look after my instruments, and it's part of it. Also, when you're in the middle of debridement, and you're let's say I'm scaling the mesial aspects of a lower molar, I'm using my 11-12, I'm going deep into the gum pocket, and I'm thinking, it just feels dull, and I'm having to put a lot of pressure, and why am I leaning into it? If you feel, God, this is a stubborn bit of calculus, and I'm leaning into this bit of calculus, I'm really giving it some elbow grease, you're doing something wrong. That is the time you immediately get your test stick, okay, or a saliva ejector. They work as well. Okay, so test stick or saliva ejector. And sorry, there's things beeping up everywhere. And you treat it like I treated the pencil or the egg or the tooth. You just keep the terminal shank parallel to the test stick. And if you hear that nice click sound, well, I'll put it near my microphone actually, because you won't hear it, will you? Can you hear that click? There we are. So if you hear a nice click sound, you know it's sharp. If you don't hear that click sharp, if it doesn't engage in the plastic, then it's not sharp. So yeah, either have one of these in your kits or your saliva ejector, because it's disposable and it's always there. And that's a really good way of testing. I had a Q&A. Gleason guides as well. Yeah, they're also, some people get on with them. I personally don't. I find it, I know some people find them really easy, but it's just the way I was taught to sharpen. That's why I use it. So no, I don't use a Gleason guide, but some people find them very effective. So when you're looking at sharpening, you need to look at anatomy. You need to look at anatomy of the instrument. You need to look at, if you're using a universal, if you're using, first of all, a scaler or a curette. If you're using a curette, after you've sharpened, you need to make sure this is continually round, okay? The undersurface. And with your universal, you need to sharpen both sides. With a blade, you need to sharpen one side. So with a Gracie, you need to sharpen one side. So if we start with a universal, let's get my Columbia. No, where is it? Here we are. Always put them back in the right order. With your Columbia, you have a flat surface here, okay? And you've got two cutting edges. Your flat surface here is 90 degrees to the terminal shank. So you always keep the instrument, the terminal shank, at 12 o'clock, okay? I hold it in my non-dominant hand, okay? I'm going to sharpen them towards you, so I'm sharpening them backwards so you can see it in the camera. I didn't think this through. Okay, and this is my Arkansas stone. You get a little bit of oil. And try not to get it on your laptop. So just a few drops is fine. Okay. So you hold your sharpening stone. I hold it in my dominant hand, so my right hand, and your non-dominant hand to hold the instrument still. I move my right hand, or your dominant hand. You keep your non-dominant hand, your left hand or your right hand if you're left-handed, still. Okay, so you do not move this arm. And the best way I do it is I put my elbow on the table and then I'm not moving it. Okay, this elbow I'm keeping off the table because it's the one I'm moving. So I'm looking straight at the toe of the instrument. Okay, so I'm looking at this bit here. I'm putting this at 5 minutes past. In the manual, it says 3 minutes past. I just say 5 because it's between 3 and 5 is not much of a difference. So I keep it at 5 minutes past and continual movements in the same direction. Now, the side of the instrument has to maintain contact the whole time. Okay, so you don't rotate this as you go along because you'll ruin your instrument. It needs to cut all the way along the blade. It needs to be completely flat. So keep it completely still. Keep it, the toe pointing right at you, okay? And make sure the stone is fully flat on the entirety of the blade, okay? After you've done it a few times, it's enough. You don't need to do it more. And if you do it after every time you have a patient, it should be a few strokes and you're done. If you let them get dull and resharpen them, that's when the mistakes happen in terms of over sharpening them and ruining your instruments. So it's really important to keep them sharp as you go along. Now, everyone sharpens ever so slightly differently, which is my feeling is that everyone should have their own set and not let anyone else use them. Because if anyone else uses them or use them to put pressure in different aspects of the instrument, you have to sharpen them back to where they were. So it's important really to keep your own, look after your own. So I would recommend for everyone to have their own set. These are just my recommendations. They're not gospel. If we move on to the sharpening of a Gracie, it becomes a little bit trickier. Here we are. Because you have to move the terminal shank. So what you have to do here is, I've done it on this diagram for you. You need to flatten the facial surface. Okay, so what I've done is this picture here, I've just rotated to here. Okay, so this picture there just shows that I've rotated it here. So terminal shank is now at 5 minutes past. So 5 minutes past the clock. And now the blade is flat. Sorry, the facial surface is flat. And this is the blade we're sharpening. Okay, so the lower surface we make flat. I'm going to turn it this to 5 past or 5-2, and then the stone exactly the same way as the universal, but the universal you've got at 12 o'clock, this you'll have at 5-2. Now if you're doing the other surface, then still have the blade pointing. You can do it blade pointing away from you, but I find that very confusing. I always have it pointing towards me, and then I'll move the stone this way, so I'll tilt it that way. So the facial surface is flat, okay, and then for the other side, I'm tilting it this way. So one's at 5 past, one's at 5-2. Okay. I didn't realize, because I'm looking at myself in a small screen, everything I'm doing is opposite on the screen. So I hope you've got that, and I hope I haven't confused you completely. Now, as you go up from a Gracie 1-2, let's say, I mean, to a 7/8, there's no difference. It's the same way of doing it. But let's say we go to an 11-12. Where's the terminal shank? It's all very confusing. Where am I sharpening it, this way or that way? Okay, hold the instrument in a way that you're going to scale. So here we are. I'm in the surface. I'm going to scale. This is the mesial aspect, the cutting edge. I'm then going to flatten the surface here. Okay, so this is the terminal shank. This point here, a bit before the blade. This is the terminal shank. It's at 5-2. The stone is now at 5 past. Okay. So it's exactly the same as the 1-2, but you've got to ignore the entirety of the instrument above the terminal shank. This is the only bit. Oh, I've got to be right in the middle of the camera, don't I? This is the only bit you care about. Okay, that's your terminal shank. That's really important to learn where your terminal shanks are on all your instruments. That's the take home. I think it's important to take home today, is know where your terminal shank is. So when you're going through the booklet on how to sharpen the instruments, which hopefully Chris can send to you guys, you can understand the terminology, which is the important thing. Okay. Any questions? I hope that's been helpful. I hope it hasn't been too basic. If there's any questions which you want me to answer,